Hi, everybody. So I'm hoping today to continue with our radiology lectures. And the last we had done a few months ago was actually on the pelvis. So if you want to refresh yourself, refresh your memory, you can always go back and watch that. And so we're going to continue with that. And we're going to start talking about hip fractures, which I hope you find interesting. Not a very long lecture or not a very long recap, because most of us do know most of this. But I just wanted to cover some things that maybe some of you may not know. And yeah, hopefully we can take it from. So this is something that we often see in our emergency departments, the posterior hip dislocation that you can see over there. Now, what happens is that in a posterior hip dislocation, number one, it's the most common. So about 90% of them are posterior hip dislocations. The simple reason being the lip at the back is much easier for the hip to pop out of. Unfortunately, when that happens, through your femoral head, you do have your main nerves and arteries and all that supply your periosteum also running through there. So you've all got a high possibility of neurovascular insufficiency, and you've also got your femoral vessels that are running over here, sometimes being pulled by the dislocation itself. And ideally, we should reduce it within 6 hours. And it's quite an easy reduction, which I'll show you just now. So what happens is that in order for this to happen, it's normally a hit from the bottom, or it's trauma from the bottom. So what it does is it causes the head to move superiorly and then posteriorly. So that's how you can see it. So there you can see the acetabulum sitting over there. Here you can see the left hip nicely in place. So what happens is this gets pushed superiorly and posteriorly, alternatively posteriorly, and then it pops up superiorly following that because of the tension of the gluteal muscles after that. So so this is, as they say, it's your extremity is shortened, markedly internally rotated, which is the main thing that you'll see. So the entire leg will just rotate internally and adducted. So looking like a shy girl in the old cartoons and movies, the shy girl would stand like that, with the finger on the lip and or finger on the lips and hiding the one leg, so that is the shy girl posture. So that's what we see in posterior hip dislocations. Now, anterior hip dislocations are not as common because it's a lot harder to get the what you call it, the hip to move out that way because of the traction from the gluteal muscles. However, it can happen. It's commonly associated with fractures and other trauma, but it definitely does happen. So what happens is this is just the complete opposite. So you have an inferior movement and an anterior movement, and there you can see it hiding over there. So as compared to our previous posterior dislocation, what will happen now is that the limb actually becomes lengthened because it's pushed out. It's externally rotated sometimes, not all the time, but it can be externally rotated and generally quite badly abducted. So you get the complete opposite. You get a hip that's lying now, let's say facing outwards. If you had to think of it as a clock, this one here would be sitting at, let's say, 6 o'clock, and this one here would suddenly be sitting at 7 or 8 o'clock with the toes pointing upwards as well. Now, luckily, we don't see this too often. It is difficult to diagnose on examination simply because that doesn't necessarily point you towards anything. The patient may just be lying like that. It may be a femoral fracture. There may be other things that you're looking at. And the reduction is quite difficult. So I haven't opted to show you all the reduction in this one because it really can be quite difficult. So this is one type of reduction technique that we're going to look at. And our doctor here, our A&E specialist, I was actually supposed to put a name, but she's quite prolific on YouTube. And she does a lot of these things in the emergency department. Hopefully, I'll just look through and just try and find the name again. So we're going to look at something called the Captain Morgan technique, because you stand like Captain Morgan on the rum bottle. And I'm going to show you the video now. Now, this is not the only way to reduce a hip. It's just a common way, a good way, and an easy way to do in the emergency department. Although I would suggest that you put your patient under sedation at least, depending on their age. And, it's mainly the elderly who are more prone to this, but it can happen at any age. And in pediatric patients, I wouldn't suggest rushing to the reduction without an orthopedic oversight, or at least discussing it with your orthopod and having them look at the x-rays as well, simply because of the epiphysis that sits over there. So you can actually cause quite a few problems for them later on, both the orthopedic surgeon and your patient by doing that. So let's have a look at this. So this is how you do the...
You have to hold push down.
Push harder.
Yes.
Push harder.
Yeah,
Okay.
you're doing counter traction.
Okay.
Yeah. She's still resisting.
Oh, there.
Good.
Good.
That's awesome.
Yes.
That is too cool. That's too cool, right?
It popped right.
Okay, so let's watch it one more time and look at what, the assistant here is pushing down on the pelvis and doctor is pulling up on the femur, using the knee as a fulcrum to enable her to do the reduction. Okay, so what it does is then it pulls the femur inferiorly, and once it comes down inferiorly, it will generally pop into place. So let's just watch that one more.
You have to hold push down.
Push harder.
Yes.
Push harder.
Yeah,
Okay.
you're doing counter traction.
Notice how she stabilizes the knee as well, so that she doesn't dislocate that.
She's still resisting.
Gentle traction.
Good.
That's awesome.
Yes.
That is too cool. That's too cool, right?
It popped right.
So you notice the gentle traction under conscious sedation makes it a lot easier instead of having your patient fighting and screaming. I mean, that's not a pleasant procedure. Your patient would actually be in a lot of pain if you did that without sedation. So try and use reasonable sedation according to the protocols in your hospital. Let's look at the others, another patient and a similar technique.
Here we go.
Starting.
Gentle.
See pelvis stabilized, knee stabilized.
You just have to push down as it pull up, right?
I am.
I just need to stay. Yeah, I went in.
And
very
notice how she had to externally rotate the
Starting.
pelvis, the femur, in order to get this one in. So it can prove a challenge sometimes, but very satisfying reduction because the pop is quite big. So you really do feel it when it goes in. There, pop, and it goes in.
I went in very smoothly.
So that's just one of the reduction techniques, but there are quite a few. And I would suggest that you learn them as well. So let's look at femoral head fractures. Now, these are more common in the elderly, not very common in trauma, sometimes associated with pathology as well. It's a difficult one on X-ray sometimes to pick up unless there's an obvious movement, and they are divided as well. So you have different types of Pupkin fractures, these femoral head fractures, but generally your patient will come in with a history of trauma, sometimes even minor trauma, as with any elderly patient, because these are more commonly associated with elderly patients, but you can sometimes get them in younger patients as well with other osteogenic problems and things like that. So here we can see a large Pupkin or femoral head fracture. So you can see the femoral head is completely moved, even though it's in place. So now you've got sort of like a fractured dislocation, if I can put it that way. And in fact, in this one, it is a fractured dislocation, which you can try and reduce. In this case, it's not a contraindication. So in other words, having this piece in the acetabulum is not a contraindication for trying to reduce that piece, because there's still quite a possibility of neurovascular injury. The thing is, I always suggest consult with the orthopedics first, for the simple reason that because of the Pupkin classification, there are certain types. For example, we have a femoral head that's quite badly damaged, or you have multiple fracture lines running through here as well, where reduction is contraindicated. But it's just something that you need to know. So in other words, if the orthopod has to tell you, okay, listen, reduce this, and then we're going to take the patient to theater, you shouldn't fight, you should say no problem. Of course, it depends on your hospital. I mean, for example, in our hospital, the reductions are all done by the orthopods to prevent these problems. But in certain hospitals, it's the emergency department that does all the reductions, you know. So that's something that you need to know. So like I see, we see the left femoral head sitting up over here, and we see the rest of it being pushed posteriorly into sort of like a posterior dislocation as well. Okay, right. So this is quite a large one that they've got over there. So now we get to femoral neck fractures. So these are the types of femoral neck fractures that you have. Now there's quite a few, but basically it just depends on the area, you know. So if it's more proximal, in the middle, distal, things like that, and you can learn the names as well, it's not a problem. The main thing with this is to understand and to recognize, because these are the most common fractures you will see in elderly patients when you are working in an emergency department or an orthopedic department or whatever it is. And these, as you can see, it mimics a a posterior dislocation, although the adduction is not as severe. In fact, you don't get much adduction. So you still get the external rotation and the shortening. Okay, now I must be honest, having seen more of these dislocations than most of you would have, the shortening in a posterior dislocation is a lot more marked. So you probably see it there, and you see the leg sort of sitting here. Oops, sorry about that. Sorry. So you'd see the leg sitting here, and like I say, you'd see the toes sort of pointing. You'll see the leg sitting here, and for an external anterior dislocation, then you'd see the leg move that way with the toes pointing upward. Sorry, I just got a bit mixed up over there. So that's how you recognize it, and it's a classic thing that we've all been taught: external rotation with shortening of the limb. So that's really something that you have to know, and you have to be able to recognize, simply because it is so common. So how do you manage these patients? Here we can see some of them. So that's more through the middle. That's just below the head of the femur. Distal. Sorry, that's quite a distal fracture. So the question is not only what recognize is how do we manage it, because these patients are in a lot of pain, and the pain is probably the most significant part. Now, obviously, if you have availability of skin traction or even proper traction, you should apply it as quickly as possible, or get it applied as quickly as possible. Now, for most of us working in a relatively advanced hospital, most of your nursing staff, a lot of your plaster techs are all trained in putting up the tractions properly. So try and get traction in as quickly as possible. We're going to talk about femoral nerve blocks just now, which also help for that. But analgesia. Get this person calm and comfortable, because this is one of the most painful fractures that you can have. So what happens is they start releasing adrenaline, they start releasing cortisol. And unfortunately, in the most of the elderly patients that this happens in, you've already got cardiorespiratory dysfunction. So what happens is that you push these patients into higher levels of failure. They start developing renal insufficiency. You start getting so many problems that are going on with them that you really need to control that pain. And once you get that pain under control, you've done quite a bit. Now, these are don't commonly bleed that much in the elderly, as when we'll get to the main shaft fractures, but you can get a bit of blood loss. So just watch out for that as well. So moving on to the next one, and like I said, we're going to get on to a bit more management later on. So these are intratrochanteric fractures. Now you get fractures isolated to the greater and the lesser trochanter. I didn't really want to concentrate on those because they aren't as common and relatively easy to deal with compared to these. Now, this is the trochanter. So we know the head, we know the neck, and now we know the trochanters, all right, or the intratrochanteric area. Okay. So these are intratrochanteric fractures. They can happen at any point around here. And then once you start going below that, then you start getting into, let's say, femur shaft fractures. Or subtrochanteric fractures, which are also relatively common. Now, intratrochanteric fractures, also relatively common, more common in the elderly, are often associated with femur neck fractures as well. Also present with a large amount of pain, although there isn't much shortening associated with them, or rotation and things like that, although it depends on the type of trauma that occurs as well. So you can have, for example, this piece knocked back, and it can happen. It's a different classification of these fractures, which is not important in an emergency setting, but you can have that. Now, are they associated with other trauma? Yes, especially pelvic trauma, depending on which direction the trauma came from. So generally, most of the trauma comes from falls. It's not as severe in the pelvis, but you can look at the acetabulum and the rama. You do sometimes get injuries there as well. Okay, so these are just some x-rays just to show you intratrochanteric fractures. So here you can see the lesser trochanter has been displaced completely. You can see the fracture line running through there. And again, you can see your fractures running through here involving the greater trochanter as well. Here we can see from greater trochanter to the lesser trochanter. And this one you can see, you might find a patient with a bit of external rotation and shortening of the limb. So it all depends on what you find. But remember, these patients, the most important thing is traction. Femur neck trochanter, traction, analgesia. I can't stress that enough. Now, not to the point where the patient starts having side effects from the analgesia, but just so that you can at least get them under control. Now, for the reductions, I would suggest propofol. The simple reason being that most of your elderly patients are either hypertensive or have cardiac failure and things like that. Propofol tends to be a bit easier to use than ketamine. The best to use is ketofol, but most of you have not been introduced. So ketofol is a combination of ketamine and propofol, which kind of, so each counteracts the negative effects of the other. But whatever conscious sedation you can use, even a bit of Valium, a little bit of dormicum, some morphine, just something, just to get the patient's pain under control, and you can quite easily do the reduction. Beware of patients who have had CVAs, patients who are suffering with any sort of paralysis and things like that, because they may not need any sort of sedation whatsoever, and you'll be able to do these quite easily. But the one thing I wanted to mention is that often in paralyzed patients, you may not get them early on because they won't complain of pain either. So sometimes it's only after a few days, the family notices bruising, there may be a bit of sepsis setting in, large hematomas, there may be something else like that. Then you might pick it up, but those are not very common, I must be honest. Generally, patients tend to fall, ironically, on the unparalyzed side. Don't ask me why, but it tends to happen like that. But you do get these, all right? So, like I say, immobilize the limb, analgesia, get bloods, including the cross match, just to make sure that if the patient does need blood, then you have that ready to go. And a femoral nerve block as well, which we're going to talk about now. So a femoral nerve block generally is done under the guidance of ultrasound. So what happens is that you go to where you would try and take your femoral blood gas, for example. So there's your femoral artery, your femoral vein, quite large over there, which would be medial. And then this would be the middle. And then this is what your femoral nerve looks like. So what will happen? Let me just try and get a drawing in there. Sorry about that. Okay. So let's try and get this in a nice color. Sorry, should have set this up before, but didn't. So what would happen is that you would actually see your needle point come through from the skin, and then it would slowly come down, and it would continue going down. Now, the worst thing you can do is actually put your needle point in there. Because once you do that, what you're going to do is you're going to inject lignocaine directly into the nerve, or whatever you're injecting, bupivacaine, whatever it may be, and you're going to cause a severe neuropraxia. So what you're actually aiming to do, let me try and clear those. Let's do it again. So what you're actually trying to do is that you're trying to go from this point. So what you notice is you'll use the bouncing technique. So you will move your needle up and down so that you can get to the point. And then what you'll do is you'll try and get till about there. So once your needle point is there, then what you'll do is that you'll start injecting the lignocaine. And what will happen is that it will actually start to form sort of like let's say a ball. Let's do it like that. So you'll see like a ball of lignocaine, and this yellow part would actually get pushed down. And that's how you know you're kind of in the right place. So you get a flattening of this because you've got lignocaine above there. And the lignocaine, of course, will affect the, the myelin sheathing as it normally works, and you would eventually get anesthesia in that area. So what that does is that actually affect it. I mean, it sorts out the pain that's going through the femur. And this is even for femoral shaft and things like that. So you get this lovely anesthesia, analgesia that's going through. I've used it on pediatric patients as well, although you should be at least quite familiar with doing it on adults before you attempt it on children. And what happens is that it actually makes it a lot easier for them to tolerate reductions, and it reduces the need for a lot of sedation and things like that. Okay. All right. And that's the end. So I hope you guys enjoyed it. We'll talk more about the femur, then we'll try and get into the knee in the next few weeks. And the knee is always a difficult one. And then we'll try and finish off with the foot and the leg. And then hopefully we'll come back to chest x-rays after that. But next week we'll be doing a different, most likely an ECG. And if I come across any good cases that I can discuss with you guys, then I'll do that as well. But I hope you'll enjoyed it. And yeah, we'll take it from there soon. Okay, keep well. Bye.